Sir, we are live now. Hello.
हाँ, यस बोलिए.
Yeah, sir, we are live now.
अरे पर आपके स्क्रीन में तो कुछ और दिखता है. Why are you not understanding this?
Yeah, sir, that's a different cover, sir. That's a different cover. We are
Okay,
live.
what I do? Share screen.
Yeah, you can start by introducing yourself, and then you can share the screen.
Okay, fine.
Yeah.
Good evening, friends. At the outset, I would like to profusely thank the IJCP publication group, the Med Talks, for giving me this opportunity to interact with all of you, my dear friends, on an important topic of an update on the management of neonatal jaundice. Well, I am Dr. Umesh Khurana, and currently I am a professor in pediatrics at CCM Government Medical College, which is located in Durg district of Chhattisgarh. After completing my MD in pediatrics way back in 1980, I have served in various capacities, heading neonatal units of Steel Authority of India Limited, and I have been trained at New Children's Hospital, Sydney, Australia, in neonatology. I am a national trainer for various programs. The famous NRP program, the Neonatal Resuscitation Program. Then infant and young child feeding. I am a national trainer in IYCF of BPNI. And also I'm a national faculty of the Nurturing Care ECD program of Indian Academy of Pediatrics, life member of Indian Academy of Pediatrics, NNF, Adolescent Health Academy. Presented several scientific papers and have got several national and international publications. So I think without wasting any more time, I would like to share my screen and start with the presentation on today's subject of recent updates on the management of jaundice in the newborn. Well, in this slide, you see a deep yellow jaundiced baby. Now, this condition is quite common. Jaundice in newborn is very common. Well, in majority, it is physiologic. Physiologic, that means because the liver is immature, there is fetal hemoglobin which hemolyzes. There is a liberation of hemoglobin which converts itself into bilirubin. And the liver is not that mature enough to handle this load. And therefore, around 50 to 60% of newborn, they develop physiologic jaundice. This appears on second to third day. And then it disappears in 1 week time, around 7 to 10 days. This is self-limiting. That's fine. This happens. It's wonderful. But then rarely something very, 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 very complex takes place. And that is the unconjugated bilirubin trickles down into the brain and deposits itself into the various important structures of the brain, especially basal ganglia, substantia nigra. And as we see in this slide, all this thing is yellow staining, and this leads to a permanent handicap, which is called as kernicterus, leading to lifelong disability. The baby appears like this during the neonatal period, opisthotonus, stiffening. So our objectives have to be to prevent this condition, because this is a permanent disability. And management of neonatal jaundice focuses on prevention of newborn encephalopathy. Now, also, we will subsequently see that this is linked with promotion of breastfeeding in decreasing maternal anxiety. In this presentation, we'll be talking about education of all stakeholders who are involved in the management of jaundice. What are the various cost-effective innovations which we have, and what is the new home-based management on neonatal jaundice? Well, on this photograph, we see this is the radiant warmer, and these are phototherapy units. American Academy of Pediatrics internationally had recommended in 2004 various guidelines. In 2009, there was a commentary on the various observations of these over these guidelines. And recently in 2022, these guidelines have been updated and modified. Now, these guidelines are of universal nature. They have to be practiced in all hospitals, whether it's a small hospital or a large hospital. All pediatricians, neonatologists, nurses, community health care providers. So it is of a universal nature that these guidelines are there. It's a protocol. So if we see this 2004 publication, we find that these are various steps. Step one, this is the newborn infant. Step two, you have to assess the jaundice every 8 to 12 hours. Evaluate whether the jaundice is present or not. If there is no jaundice present, it's perfectly all right. See whether a bilirubin has been done. Is the newborn ready for discharge? Or if there are any risk factors, then those risk factors have to be evaluated. The discharge will then be not possible. So all these are then, if suppose jaundice is present, then serum bilirubin has to be measured. And this serum bilirubin has to be measured. And accordingly, depending upon the serum bilirubin level, one has to do the management. So it's a very, very well-defined protocol, which is available almost in every department of pediatrics in India. Now, these AAP, American Academy of Pediatric recommendations, have certain codes. So this is a recommendation code number 1.0. This is recommendation 1.1. And evidence quality. So evidence quality, if the evidence quality is C and above, that means C or D, it means the benefits are more than the harms. And therefore, these recommendations have to be definitely followed. Now, the fact is that the breastfeeding, it improves hydration. And whenever there is improvement in hydration, all the metabolites will get excreted in urine and in stool. Breastfeeding decreases enterohepatic circulation of serum bilirubin. Entero means intestine, and from intestine, bilirubin reabsorbs into the circulation. So breastfeeding decreases enterohepatic circulation, and therefore breastfeeding decreases neonatal jaundice. The recommendation 1.1 is there has to be no supplementation of water or dextrose water. The only thing that we have to give is breastfeed the newborn for the first 6 months. Recommendation 2.2.1 is, and it is evidence quality is D, benefits are more. Benefits are, in fact, the benefits are exceptional. We have to follow the protocols. Whatever is the protocol, because these protocols have been developed by huge, powerful committees of America. And these protocols have been developed after extensive research throughout the globe. And therefore, we have to follow these protocols. Commonly, the question is this. Sometimes we talk of two headings, breast feeding jaundice and breast milk jaundice. So breastfeeding jaundice means that in this situation, if suppose there is a dehydration, especially in summer, and breastfeeding is inadequate, the jaundice will increase. You breastfeed, it will increase enterohepatic circulation. There will be adequate feeding and bilirubin will fall. So the treatment of dehydration is breastfeeding. You don't have to give any fluid. This is a very common thing. But in breast milk jaundice, there is no dehydration. There is increased enterohepatic circulation of bilirubin, and there is a role of one enzyme, beta glucuronidase. It may lead to some prolonged jaundice, but then this prolonged jaundice is there, but it is harmless. In this situation also, breastfeeding has to be continued. Recommendation 2.0 is that all pregnant women has to be tested routinely for blood grouping in both ABO system and RS system, because we have to diagnose RH negative or RH positive, and we should know the blood group, because this forms the basis for the diagnosis of various hemolytic disease of newborn. So this is what is the routine blood grouping which has to be done of the mother, and then later on when the baby is born, blood grouping of the baby is done. The evidence quality is C, benefits are more, and if, however, the mother is RH negative, or if the mother is ORH positive, in that situation, one has to keep a close watch on the baby's blood group to rule out hemolytic disease of newborn. And if there is jaundice, we may have to get this test, which is called as the direct Coombs test. Recommendation 2.1 is that all infants should be monitored every 12 hours, not only clinically, but by this instrument, which is a non-invasive TCB, transcutaneous bilirubin monitor. This is the transcutaneous bilirubin monitor. Blood is not taken. Just it is the monitor is kept on, you can say here, forehead, and the bilirubin level flashes. So this is a very, very useful instrument, and because we do not withdraw the blood, and we do just a non-invasive transcutaneous bilirubin measurement. So this is that same transcutaneous bilirubin meter that was of, you can say, this is one Drager company. This is a Philips company, right? This is another third company. Okay, so there are various manufacturers, and this is the level which we can see is, the level is 14.5. This is also Minolta company, 14.4 transcutaneous bilirubinometer. So we have to measure this because visual estimation can lead to errors. So there has to be documentary evidence, a record of transcutaneous bilirubin level. So now in 2004, this nomogram was established. This is the nomogram. So on this X side, we have got measurements. So there are days and hours. You can say we have got lines of 4 hours each. So this is what it is: 5 days, 4 days, 3 days, 2 days, 1 day, 48 hours. So this is the time. This is time. And this is the bilirubin level. So we plot between the time and the bilirubin level, and we get these lines and we get this nomogram. If it is below this dark line, this means the baby is in safe zone. Nothing has to be done. If it is above this, and these are dotted lines, if it is above dotted line, this means we have to do exchange transfusion. And in this road between these two lines, if the bilirubin level falls, we have to give phototherapy. And these are the various phototherapy. So this was the nomogram, which was established in 2004. Now, after 18 years, let's see what has happened. This is again the nomogram of 2004, where also this is the low risk zone. The level is low. It's a low risk zone. This is a high risk zone. So if there's a high risk zone, do an exchange transfusion. If there is a low risk zone, then do nothing, just breastfeed. And if it is intermediate zone, we have to just repeat bilirubin levels and offer phototherapy. That was 2004. And what are the risk factors? The risk factors are high risk. What are the high risk? Jaundice appearing within 24 hours. Blood group incompatibility. Mother is Rh negative and the baby is Rh positive. Bilirubin in high risk. Baby is preterm, or there is some bruising or cephalohematoma. Minor risk factors is a little jaundice before discharge, intermediate risk zone, a term baby, baby of a diabetic mother, and almost no risk factors. That means if it is a term baby and the bilirubin is in the low risk zone, the baby can be safely discharged. But then this was the guideline for exchange transfusion, which was there offered in 2004. That means if it is a high risk zone, then exchange transfusion has to be done. But things have changed. Things have changed. Let us move to 2022. Pediatrics, August 22, this is the reference. And these are the important authors who have compiled a very important report, technical report of various committees on jaundice. And this has been published in the form of Diagnosis and Management of Hyperbilirubinemia in the newborn infant 35 or more weeks of gestation. What does this say? Let us understand. Accumulated evidence of literature all over the world, various studies, justifies narrowly raising phototherapy treatment threshold. That means वो जो phototherapy की line है, उसको और ऊपर करना है, meaning thereby that at present we are giving unnecessarily phototherapy. हम phototherapy ज्यादा दे रहे हैं. We are giving more phototherapy. This is what is the feeling of the world. तो हमको phototherapy को थोड़ा सा कम करना है, breastfeeding को ज्यादा करना है. Mothers, they have anxiety because phototherapy is given in NICU. and the baby is in maternity ward. So mother feels, पता नहीं मेरे बच्चे को क्या हो गया, मेरे बच्चे को jaundice हो गया. My mother is in NICU. And also her questions are not answered. Nobody is counseling her that this jaundice will go off. So she is having anxiety. And because of her anxiety, her breast milk decreases. And this further increases the jaundice. So they have found that between 2004 and 2022, in all this period when the studies have been done, they found that the breastfeeding rates have declined, and to a tune that just because of jaundice, 36% had to discontinue breastfeeding by 1 month of age. मतलब ये है कि jaundice का मैनेज कीजिए, अवश्य कीजिए, but not at the cost of declining breastfeeding. मदर की एंजाइटी को भी देखना पड़ेगा, ब्रेस्ट फीडिंग को भी प्रमोट करना पड़ेगा. So now, this is, you can say, history. Up nomogram of 2004. This we were discussing till now. The lower risk, the higher risk, and the medium risk. There are only 3 lines. The red line, the blue line, and the dotted green line. But you see 2022, what has happened. Phototherapy thresholds. Now you can say 1 line, 2 line, 3 line, 4th line, 5th line. There are many lines are there. Okay. And this is what it is: 12 hours, 24 hours, 36 hours, 48 hours. So you can see that अब ये ऊपर कर दिया गया है. मतलब जो है कहने का है कि अब ज्यादा बच्चे नॉर्मल में आएंगे, फोटोथेरेपी देना है तो बिलिरुबिन लेवल और हाई होना चाहिए. दिस इज द मैसेज. पहले ये देखिए, पहले कम बच्चों को नॉर्मल जोन में थे, अब ज्यादा बच्चे नॉर्मल जोन में आ गए in 2022. This, so now we will follow 2022 nomogram. Also, modified bilirubin-induced neurologic dysfunction, BIND-M algorithm has to be used in evaluating severity of jaundice. तो हमको इसको भी अब यूज करना है in neonatal units. Score 1 to 4 means mild acute bilirubin encephalopathy. Score 5 to 8, moderate acute bilirubin encephalopathy. And score 9 and above is severe acute bilirubin encephalopathy. This is has got a very high sensitivity of 90.7%, specificity of 97.7%, a positive predictive value of around 89%, and negative predictive value of around 98%. So this score is very, very important. How to do this score? These are the 4 headings. Mental status. It करना है just on a computer box. Normal, sleepy, decreased feeding, lethargic, poor suck, irritable, semi-coma, apnea, seizures, or coma. So if suppose there are convulsions or apnea, the child will get a score of 3. The higher the score, the more is the problem. Muscle tone, normal, hypotonia और hypertonia, opisthotonus जो हमने बच्चे को देखा था, सिजरिंग, opisthotonus हो गया, hypertonia हो गया, score is 3. Cry, normal cry है 0, shrill cry है it's 2, cry absent हो गया है it's 3. Eye movements, normal, it's 0. But suppose there are conjugate movements हो रहा है, paralysis हो गया है, 3. So यदि ये 9 के ऊपर जा रहा है, forget the bilirubin level. Forget the bilirubin level and do an exchange transfusion. What more is there? Lots of research has been done between 2004 and 2022. And they have found that babies who had jaundice during neonatal period are having either allergic rhinitis, various types of allergies, or atopic dermatitis, or asthma, allergic conjunctivitis, or urticaria. Allergic tendencies are higher with jaundice. So what does this mean? Is there any relationship between that bilirubin molecule and development of allergy later on? This is being worked out. How to do follow-up? So follow-up we do with this same transcutaneous bilirubin level, or we take out the blood. We take out the blood and do a bilirubin estimation. We do a bilirubin estimation and then we do a charting. All nurseries should have equipments to provide intensive phototherapy, because this phototherapy is treatment of light, and this is very, very helpful. Intensive phototherapy, if started in time, will decrease the need for exchange transfusion. And this is what is phototherapy. This is the bilirubin molecule. These are various bilirubin molecules. And if blue light comes onto the bilirubin molecule in this irradiance, say between 440 to 480 in this irradiance, then there is oxidation and this molecule breaks and gets converted into, it converts itself into water soluble. And this water soluble is easily excreted in the urine. So this is blue light. And this blue light in this spectrum, it breaks the bilirubin molecule, which is easily excreted, in the urine. How much light phototherapy equipment is giving? We have to measure with the help of a flux meter. The irradiance has to be measured. So these irradiance values are there. We have to measure the light with the help of flux meter. So we need a irradiance of more than 35 watts per centimeter square. This is provided by special blue tube lights, Philips TL52 of 20 watt size. We can also use fluorescent white tubes if blue is not available. If there is a white lining of the bassinet, then the light reflects and irradiance increases. Even in aluminum foils increases light exposure. This is the flux meter which we were using. So once again, this is the nomogram, earlier nomogram. And now we have got new nomogram for exchange transfusion thresholds. Higher level is needed now for starting the exchange transfusion. Exchange transfusion is something which is a very, very complex and procedure. It requires exchange of blood. Sometimes, if not done properly, there can be severe reaction and there can be an acute medical emergency. And therefore, exchange transfusion has to be done only by experts in well-equipped units in a proper way. Stage transfusion should be performed in an ICU with full monitoring and resuscitation facilities. So if the score is high, one should immediately do exchange transfusion in an ICU. Now, sometimes what happens is that we get high level of conjugated bilirubin. And if we get high level of conjugated bilirubin, we have to investigate in a different way because there can be associated urinary tract infection. So we have to collect the urine, get the urine culture done to exclude UTI. If jaundice is persisting, there can be a neonatal hepatitis. Sometimes there can be biliary atresia. We have to do some scans. But in every child, in every newborn, we have to do a basic screening for hypothyroidism, G6PD deficiency, that is Guthrie test. Every newborn before discharge, usko sample bhejna hai to rule out hypothyroidism. TSH level has to be done of every newborn. If suppose there is a RH incompatibility, in that situation, we may have to give human normal immunoglobulin. But then, latest research says that this should be given only and only if it is indicated, because there is also some studies to suggest that it can lead to harm instead of benefit. If the serum bilirubin level is high, one has to give serum albumin. This is the recommendation 7.1.5, and albumin binds bilirubin and it prevents the entry of bilirubin into the brain and decreases the tendency for cardiac arrest. All hospitals, it is the duty that all hospitals should provide handouts educating about the newborn jaundice. This is in English, but suppose if it is Maharashtra, it has to be in a different language. If it is suppose UP, it has to be in Hindi. It has to be in local language, and this has to be given to every newborn. The story of newborn jaundice. Well, this is just to inform you that I was associated with the quality circle. This is myself. And this quality circle was called as Laksh. We developed this phototherapy unit by converting a small British type ka Sorrento cot into a phototherapy unit. And double surface phototherapy unit was developed, innovated. This was presented in a conference in South Korea, and our team was awarded. So this is innovation. Well, one has to think globally, but act locally. In India, we have got good number of neonatal units. But if we see the neonatal units, majority do not have transcutaneous bilirubin estimation equipment. Majority do not have flux meters. Okay, so there are problems. Parents are not given any counseling. And this leads to the universal screening for exclusion of hypothyroidism is not done. What does this boils to? Today, we are living in a world where people are educated, and if a baby develops handicap, there is a risk of litigation, consumer forum. Anganwadi workers, they go home to home. The methanins, they go home to home. They have to be given training for neonatal jaundice so that they can manage various myths. Even today, in villages, children and newborn are taken to various these witchcraft persons for management of neonatal jaundice instead of bringing to the hospital. So this is what it is. This is a nurse. She has to be saluted. She's a nurse from England who observed that the neonates close to the window developed less jaundice. She told to the director professor of that unit, and this led to the birth of phototherapy. So the nurses have to be saluted. This is the mother, and this is the baby, and this is phototherapy. This is now is the trend. माँ और बच्चा सेपरेट नहीं होंगे, ब्रेस्ट फीडिंग चलती रहेगी, फोटोथेरेपी चलती रहेगी, दोनों का कॉम्बिनेशन चलेगा, and this is called as family centered phototherapy, and this will lead to a pink healthy baby. Thank you very much.
Hello. Hello.
Yes.
Yeah, sir. There are some questions also now. So we'll be posting one by one questions in the chat.
Well, the question is, what are the challenges to measuring total serum bilirubin values in neonatal jaundice? Well, it's a nice question. First of all is that you are taking blood in a small baby. So whenever you are taking blood in a small baby, if you are taking blood directly in that situation, you have to have an expert nurse or a doctor to take the sample. This bilirubin sample should not be hemolyzed. सही तरीके से free flow sample आना चाहिए. Otherwise, it will get hemolyzed. The sample has to be sent in a proper time, in proper vial to the laboratory. And वहां से process होके, it will come to you. The laboratory should have very good equipments to read that serum bilirubin level. So these are various things which have to be sorted out for the management of the serum bilirubin values. And therefore, one has to do quality checks. It is every equipment, every neonatal ICU should have a transcutaneous bilirubinometer, A, and B should have a very good laboratory setup for estimation of serum bilirubin, and there has to be quality checks in the laboratory to see to it that the levels are perfect and normal.
Hello. Yes, sir. I have posted the second question in the chat.
What is the role of bilirubin conjugation in the pathogenesis of neonatal jaundice? Well, if we see bilirubin metabolism, the unconjugated bilirubin and the conjugated bilirubin. So conjugated bilirubin is something which is water soluble. Okay. Unconjugated bilirubin is fat soluble. Unconjugated bilirubin will go to the brain. Conjugated bilirubin will pass in the urine or in the stools. So bilirubin conjugation is with the help of one enzyme, which is glucouronidase, which is there in the liver cell. Now this enzyme activity, the activity of this enzyme is not good if the baby is preterm. If the baby is premature, the conjugation will not take place properly. Or if there are certain, reversely, sometimes certain drugs are given, example say phenobarbital, which helps in conjugation. So this is, and sometimes if suppose there is sepsis, neonatal sepsis, it will lead to increase in the level of a conjugated bilirubin. But for American Academy of Pediatrics purposes, one has to have estimation of total bilirubin, conjugated as well as unconjugated. Normally, the level of conjugated bilirubin should be less than 20% of the total bilirubin. And if the conjugated level is high, then one has to investigate in a different line, that is differential diagnosis of conjugated hyperbilirubinemia. One has to exclude biliary atresia, neonatal hepatitis, and all other conditions. What is the role of bilirubin clearance in the etiology of breastfeeding jaundice? I have told breastfeeding jaundice. Okay, breastfeeding is wonderful. Breastfeeding is superb. It will decrease the enterohepatic circulation. It will increase the blood glucose level. It will increase the hydration level, and therefore it will help in bilirubin clearance. Always breastfeed. Always promote breastfeeding, and the babies will have lesser jaundice. It will lead to better clearance of jaundice. Breastfeeding helps in better clearance of bilirubin. What immediate action should be taken if neurological symptoms are presented? Go for an immediate exchange transfusion. Take a consent and go for an immediate exchange transfusion, sir. Okay, because यदि आप delay करेंगे, that bilirubin molecule will get deposited permanently. It will lead to permanent handicaps. Do not waste time. चाहे रात के 2 बजे करना पड़े, exchange transfusion has to be done. What information is elicited from history of pregnancy and delivery in cases of neonatal jaundice? Cases of neonatal jaundice. So history of pregnancy. Pregnancy means, suppose there is many abortions are there. So if there are several abortions, whether it is due to hemolytic disease of newborn, whether mother is having some jaundice, because that jaundice can lead to jaundice in the baby also. There can be other infections, you can say some virus diseases, say hepatitis A or other hepatitis can, if suppose mother is there, तो baby में भी वो हो सकता है. Delivery room में, okay, delivery में, right, in case of neonatal jaundice, if suppose it is RH incompatibility or whatever it is, then we have to take cord bilirubin. उसी समय blood लेना पड़ेगा, और हमको यदि incompatibility है तो उसको estimate करना पड़ेगा. And if there is a clear cut case of RH incompatibility, sometimes amniocentesis is done. an amniotic fluid serum bilirubin estimation is done. And if it is really very, very high, then in selected centers, intrauterine transfusions in RH incompatibility is also done.
Hello. Hello, sir. Am I audible?
Yes, please.
Yes, sir. We are done with all the questions, sir. Yeah.
Okay, fine.
And thank you very much,
Sir,
sir,
ऐसा
for your...
है, hello.
Yes, sir.
Hello. Sir, I want a email
Okay, okay,
on the complete feedback of the program, sir.
okay.
That
okay.
means how many had attended, what was the feedback.
Okay, okay. Okay, sir. No problem.
Okay, okay.
Sure,
ठीक है ना
sure.
बेटा?
Yes, sir.
Thank you, sir. Thank you very much.
Thank you very much, sir, for your time, sir.
Thank you.